All right, thanks so much, Magnus. And again, thank you all for being here. I've been tasked with talking about clinical trials and research as it relates to PBC therapy. And I think when the first time patients hear about a research program or clinical trials, they sort of think about this division between clinical care and research work. And I hope to be able to convince you by the end of this discussion that this is all part of the care pathway, and one can't really happen without the other. And so I'm happy to talk and engage, and hopefully we'll learn something by the end of this few minutes. So what exactly are clinical trials? So the National Institute for Health defines clinical trials as research studies in which one or more human subjects are prospectively assigned to one or more intervention, which may include placebo or other control, to evaluate the effects of those interventions on health-related biochemical or behavioral outcomes. So this sounds pretty technical, but it's a study, or clinical trials are investigations where you may be assigned to a treatment arm, which may or may not be a drug, or a placebo control, and that may or may not be part of the study, to investigate outcomes. And these are done, broadly speaking, fundamentally to learn, for patients to learn, for clinicians to learn, for the community at large to learn. But in fact, they're the only way to get regulatory approval for new therapies for disease and for symptoms. So they're required for us to get drugs that are in development to clinical use. And people ask often, what are the benefits and what are the risks? And these are small lists. There's lots of benefits and there may be some risks, but I've just outlined a few here. Some benefits include early access to novel therapies that might be potentially beneficial and we think could be potentially beneficial. There's close monitoring in a clinical setting by a research coordinator and by a principal investigator who may or may not be your primary physician. There's meticulous monitoring for safety with very high standards to ensure that nothing bad happens. And broadly speaking, again, you're contributing to the greater good of learning, and that's part of the benefit of clinical research and clinical trials. But are there risks? Of course, there's risks with anything we do in life. There's risks walking across the street. We all know that. The risks are, some risks for therapeutic studies include that these agents are not regulatory approved for the most part for earlier phase studies, and there is some potential that these trials are unsuccessful and there could be some harm. We can't say for sure that that's not part of the process. There's a potential that you may be treated with a placebo control. There may be unanticipated adverse events, but again, as I tell you, there's a meticulous safety monitoring behind clinical trials, and there's some commitment to study visits that are part of the process. But clinical trials are complex. It's not just one phase of studies that we do. We work along this continuum of preclinical studies, which is a lot of animal work or work that happens in the lab with cellular work that's before these drugs or therapies come into testing with people. Then there's early phase 1 studies in small numbers of patients that are really dose ranging to find what's the right dose for this agent that we should study in bigger populations. And that's to determine, one step to determine safety. And as you move along the clinical trial pathway or the drug development pipeline, you need to study agents in more numbers and in broader populations to see whether it'll be efficacious on a large scale. So phase 2 studies are really designed to test efficacy and safety of drug compounds. And as things move forward, phase 3 studies are required for regulatory approval. And then we move on to post-marketing. When a drug becomes on the market and is being used by the general population, is there anything that we're seeing that we didn't see in signals in early phase studies? So clinical trials are necessary for us to get through this pipeline, this pathway, and they require both patient and clinician engagement. These, as I've said many times, these are required for drug development and for learning, and they're really impossible, as you can see, without patient participation. And I'll make the point, and we've seen this with PBC, that this is so especially imperative in uncommon disease because we have limited patient numbers. And so we need to engage the patient community, not only locally, nationally, and internationally, to get timely recruitment of patients so these studies don't last 20, 30, 40 years when they become irrelevant because it's just taken too long to get enough patients to study. And aside from that, long studies, as you can imagine, are hugely expensive and difficult to do. But as Gideon mentioned earlier this morning, not all trials are with therapeutic agents. And I think one of the points I want to make is that we should try to think about our clinic as a continuum of learning and clinical care, recognizing that the biggest priority at the end of the day is your clinical care. That's not superseded by anything. But not all trials are for drug development, and you have the opportunity to participate in research that's related to registry work. So one good example of that now is the CANAL program, which is the Canadian Network for Autoimmune Liver Disease, that's collecting patient data, both retrospectively, so your past data, currently at your clinic visits, and moving forward. And we need all of this type of data to understand past behavior, current behavior, and present behavior, and avoid the bias that's associated with just including one type of data. So these are registries that requires questionnaires, your information, your consent for us to look through records to try to understand whether there's differences in patterns in patient clinical presentation and behavior in different parts of the country, in different patients of different backgrounds, different genetic makeups, things like that. And why are these studies necessary? Sorry, I'm going to take a minute. I'm obviously a little bit unwell today. These studies are necessary. The clinical trial development pathway is necessary for us to get drugs to you, right? That's why we do this. So URSO required these studies, and we learned so much. It took a long time. It was the only drug we had available for so long. But you can see here, these lines are just representative of survival. So the higher line means survival or transplant-free survival is better. The lower line means transplant-free survival is worse. And you can see that we showed that URSO therapy is associated with an improvement in survival compared to those patients with PBC who are untreated. And that required studies to do, right? We wouldn't learn and we wouldn't collect this data if we didn't have patients to learn from. And these studies have shown us that blood tests, I don't think that there's a pointer, but blood tests can improve in patients with PBC that are treated with URSO. That's why we use the drug, because when your blood tests improve, that's been shown to be a surrogate marker for prognosis. So a decline in your alkaline phosphatase or a decline in your bilirubin or normalization of the bilirubin is associated with improved outcomes. So when we can see that on your blood tests, we know that we're getting a signal for improvement. But we all know that not everybody responds to URSO. There's a proportion of patients with PBC who will not respond to URSO. So while it's a great drug in all patients with PBC, there's still a proportion of patients that needed something else. And that was really our community's unmet need. What do we do for those patients who don't have a perfect response to URSO? And so the international community rallied together and developed an international cohort of more than 5,000 patients with PBC, which was a trial or a study to collect the data to see what blood tests can we follow that'll accurately predict outcome, not in 20 years. What can we check early on? 1 year after therapy with URSO, I need a quick, easy test to tell me whether this patient will do better or this patient will do not so well. And those patients that are at risk of not doing so well, let's get them into studies or trials, or let's learn so we are able to find drugs or options for them that'll improve their outcome. So the Global PBC Study Group put together this large data set that showed that a decline in alkaline phosphatase to less than about 2 times the upper limit of normal and a normal bilirubin is associated with improved prognosis in patients with PBC 1 year after therapy. And that data was what allowed us to get additional therapies like obeticholic acid on the market as quickly as we were able to. We didn't have to wait I mean, URSO was the only thing from 1994 until 2017 in Canada, right? These agents got through the development pipeline pathway with these surrogate outcomes that we were able to identify through these research studies that allowed us to see that obeticholic acid can improve blood tests further in patients with PBC with a suboptimal response. So the details around these graphs are not that important, but you can see the blue and purple bars show that about 50% of patients who have an incomplete response to URSO have an improvement in their blood tests when they take obeticholic acid in addition to URSO. So is this good news? Yeah, it's good news. It's a new agent that we might potentially have to allow benefit in patients who previously had nothing else that was working well enough for them. But that still means that there's a proportion of patients that don't meet that endpoint and still have elevated blood tests despite URSO. So the job is not done, and to get this number to 100% of responders requires us to work more together, to learn more together. So I just wanted to spend a few minutes to talk about what we've done through this data that we've collected through CANAL already and through our learning from using obeticholic acid in the real world setting, because patients that participate in clinical trials are not exactly the same as patients who don't participate in clinical trials. Not everybody will be eligible, and that may be based on some other medications that you're on, or the fact that you don't have access to a tertiary center where trials are going on. But when you look at our experience with using obeticholic acid with URSO in patients that are incomplete responders to URSO, we see a similar decline than we saw in the studies. So the green bars represent the thresholds that you're trying to reach. So when you use obeticholic acid in patients with PBC with an incomplete response on URSO, the decline in alkaline phosphatase happens quickly and it slowly continues over time. So some patients will say that my numbers are fluctuating, they're not taking this consistent pattern, but if you follow it long enough, they will continue to drop. And other studies are being done on other drugs. So this is a different a phase 3 clinical trial that was done in Europe that looked at bezafibrate, or a cholesterol-lowering medication, in patients with PBC. And while it does lower cholesterol, it also improves biochemical markers of cholestasis. So you can see 31% of patients who took bezafibrate with ursodeoxycholic acid had a normalization of their liver tests after 2 years of therapy. So this is research that's allowed us to develop multiple new options for patients with PBC, which is alluding to what an exciting time it is for us to be treating this disease. I'm going to go through just a few other slides for other studies that we have going on with newer agents. So this is another agent that's a similar mechanism to bezafibrate that we have in a phase 3 study right now that's called Seladelpar, that shows a significant reduction in alkaline phosphatase in earlier phase studies. So this is at a phase 2 level. The next step is to move on to a phase 3 level study. And we've alluded to this throughout the day, that we're clinicians that treat patients. I don't treat blood tests, I don't treat scans, I don't treat what's in a chart. I treat a person, and I know that every person is individual, and some people will prioritize disease control and therapies that'll modulate their disease better, but some people are miserable because of their symptoms, and that's really what we need to manage first. And so when it comes to pruritus, we also have studies that are evaluating agents that are designed to improve symptoms like itch. Magnus gave an excellent talk about the symptoms the treatments that we have available for itch right now, but as we all know, some of them work and some of them don't, and everybody will respond differently. So there are also studies that we're doing to try to find new agents that are available to treat symptoms rather than disease. And the goal of this effort to sort of merge clinical care with research is ultimately to be able to provide the optimal care for all patients. And we want to be able to provide all of these options regardless of where you are, to allow consistency of care and to ultimately offer safe, effective, and evidence-based options to improve your outcomes. And give you the opportunity to participate in research and in clinical trials if that's something you want to do. you, and recognizing that, as I said when I started, that nothing supersedes your safe, optimal clinical care. That's the priority always. So over time, I hope that we as a community in Canada can develop a care pathway that will allow for centralized clinical care, so that we're able to identify patients at highest risk early and use second-line therapies and additional therapies that we have in the appropriate patients, and talk to you about symptom control versus disease control and prioritize what's most important to you so that we can make individualized decisions about what's best to use, whether as second-line therapies, whether that be with agents like obeticholic acid or bezafibrate or clinical trials.